welcome back to the Better Birth Podcast. Today, I'm super excited about our episode with certified nurse midwife Charlette Withers and owner of Let Us Birth Midwifery based in LA. So thank you so much for being here with us today.
Thank you guys for having me. It's a really dope experience. Thank you.
Yeah. Awesome. Well, yeah, I'd love to start out by chatting a bit about cord blood banking. As you know, at Anja Health, we do cord blood banking, and I'm the founder of Anja Health. So, yeah, I like to ask birth professionals what their perspectives are on it and experiences. So, first of all, in your opinion, what are the pros and cons to cord blood banking?
Well, in my experience, I think my first experience with cord blood banking was probably just as an L&D nurse. You know, I feel like prior to like maybe 5 years ago, people would just say, hey, you know, collect this. We really didn't know what was going on or why, kind of. And then in my experience in my professional as a provider, there were opportunities for me to actually do the collecting. So I had to learn a little bit more. And so it's really an amazing, I honestly don't feel that there's any cons. Nothing but pros from what I can see is that, you know, parents can actually go back to the stem cells that they might need for their own children or for themselves, or they can donate. I've done a program where it was just, they didn't want to keep them for themselves, but they completely donated. And so for other children or adults or whatever research is coming up that we found that stem cells has been very beneficial to the well-being of people. So I'm praying that is, you know, that it extensively gets, we need more. Because that particular program was granted and so it's no longer going on in that program that I had participated in. But I think it's great when I have patients that are banking their cord blood. They're excited. They're knowledgeable. They know that they can, benefit from it, or someone can in the future. So
yeah. That's awesome. Yeah. Cool. So you have seen cord blood banking, or you've done it before?
Oh yes, I've done it several times. I've for myself per se, no, but I've participated in programs with parents who are doing the cord blood banking, and then of course, you know, when people buy kits and whatnot, I'm totally abreast and aware when patients want this. So yeah, I participated in. I actually am a very, very a good collector of my cord blood. I know how to. I got it down pat, so I'm a very good collector. I guess the cons would be when people can't collect well, when providers are not knowledgeable or not trained on how to collect.
Right.
You know, I try to have like a little contest with other people. Like, listen, I bet you I can collect the most. So yeah, I totally. I don't see any. That would be the only con I would think when people don't know how to do it. So yeah.
Yeah. What are your tips for collecting a lot of cord blood well?
This is what I think. So if the patient needs cord blood, say they need cord blood for their own self, we have to collect our own. You get just a little bit. That's enough for that. I think that's what happens. It's difficult when you have patients who want to have delayed cord clamping.
Right.
So that's another con that can. If you have a patient, that's what they want. You know, I try to just speak to them and say, hey, listen, if you want delayed cord clamping and we're doing cord blood banking, like where can we meet in the middle so that I don't allow all of the blood? We know we want babies to be benefited with mom's blood as well, but somewhere I would have to cut off so I can get a good collection. So I usually try to just, if that's not the case, get as much as I need for that cord blood, and then definitely the way I kind of clamp the cord, I clamp low so that I can fill up all that cord, and I start at the bottom rather than people start collecting from the top. But if I start from the bottom, then even if I need to cut that piece of cord and then start again. So, you know, you just have to learn how to milk it to get your optimal amount. So, and then let that bag go to gravity. It's a whole, you know, you get your whole little technique together, but let the bag go to gravity so that you can get as much as you can. So I usually get a pretty good collection.
Okay, that's awesome. Yeah, we always try to remind people to milk the cord. Yeah, the gravity tip is really awesome. Yes. So yeah, we typically tell parents to, if they want to do delayed cord clamping and cord blood banking, then we recommend that pregnant parents delay for max 2 minutes and then decide to cut it off at that point. But yeah, I guess, do you have an opinion on that amount of delayed cord clamping? Like, some people feel like they should do it longer, but I've also read that there's not necessarily any more evidence that doing greater than 60 seconds provides any more benefits. So what are your thoughts on delayed cord clamping?
Well, I'm an advocate for it, of course, but I don't necessarily like to go more than 5 minutes, honestly, because, see, some people don't know the flip side when that baby gets to postpartum, and when they start doing TCB testing on the baby, and we have an abundance of bilirubin, then baby's jaundice, that can also be very dangerous.
Right.
So I always try to tell moms, listen, I'm totally for it. I understand the benefit, but going beyond 5 minutes, like people sometimes want to, they want to go to the court, continues to post that can happen for 15 minutes.
Right.
That can totally happen for. And so I also want them to know, if you are knowledgeable that postpartum wise, this baby can have an abundance of red blood cells that could potentially make this infant jaundice. If you're knowledgeable about that, then I can go beyond, But I've seen it on both sides. I've seen babies that are fine. I've seen babies who end up on triple lights and things like that, or have to go to NICU. So that can also be a complication. So the parents should be knowledgeable on all fronts. That's kind of where I'm coming from with that.
Right.
Mm-hmm.
Okay. Interesting.
Yeah. Mm-hmm.
In the parents that you've seen do cord blood banking, why do pregnant parents typically choose to do cord blood banking? Like, is it typically because of a sick family member or just peace of mind? What are the common reasons that you've seen?
I've seen it with patients who have had like some type of genetic problems in their family, or they are just knowledgeable. They have the knowledge that, hey, something does come up, we do have this to turn to. Or people who are just, the benevolence. They know, hey, if I'm not going to use it, somebody else can. So I like that part. The fact that if they don't want to use it, then why not allow someone else to benefit?
Right.
And so. Those are my typical times. I have never had a patient or a mom or parents who said, hey, we got this problem in our family and this is what we want to do. And, I think it also depends on the demographics too, where patients and parents are given that information. I have one particular hospital, you might not see it as much, and then another one who has a little bit of different dynamics there. People are bringing kits all the time. So I think that's another thing that should happen, that even maybe the underserved population should know, why should you do this, or how can this possibly help, hey, generations back from you. I think it says up to 24 years or so that these stem cells can be used. So why not? So I think some education there, and also going to and then I understand it has a cost factor too. So hopefully in the future we see some granting where people don't have to pay, and maybe they can still do this. So yeah.
Okay, awesome. Cool. My last question related to cord blood banking is your reaction to a case study that we have on our site. So we have a case study on our site about a young boy using cord blood stem cells, so stem cells from the umbilical cord, to treat autism. So have you had exposure to that before, or what are your general takeaways from that case study?
I have read some research in regards to that type of, that diagnosis and being used with stem cells. But, of course, I've never had upfront evidence, but I believe it. You know what I mean? I believe, I know the benefits of stem cells. And I also, I know there's some information out there where people talk about, that there's like a whole industry where people are benefiting on other people's placentas and stem cells for the benefit of others and to their financial benefit.
Right.
So so when that kind of thing possibly is in the play, then it's there's something to it. But just from my research on stem cells, I believe it. I believe that if it can cure a cancer, or if it can take care of autoimmune disease and things of that, why not? Why not autism? And I think because autism is it is changing, the diagnosis is changing, the statistics, and for whom, and, where we see the prevalence. I think since that's changing, I believe that research is here to help.
Yeah.
And why wouldn't you? So I was pleased to hear that, to read that article. Yes.
Yeah.
And how fast that got me, like how fast they began to see some changes. So amazing. I would love to know more, like what happened the year after or something like that. Yeah.
Yeah, definitely. Yeah, sometimes we see folks have improvements with cord blood stem cells in just a few months. And it's even things like kids that weren't able to move like their individual toes can suddenly like move their individual toes just a few months later. So yeah, I think that's really awesome.
Yeah, it is. It is.
Awesome. Cool. Well, yeah, I know, especially since you're a certified nurse midwife, I'd love to get your take on preparing for birth and also midwifery in general. So I'd love to move into that.
Yeah.
So one question that I know a lot of pregnant parents have is, what are the signs of preterm labor? Okay.
Yes, that's preterm labor. It's a complication, and it's something that education can help. Really, it can prepare women. Signs of preterm labor. A lot of time, anytime that you are having labor signs prior to 37 weeks, which is considered a term pregnancy would be considered preterm labor. Just after a certain gestation, it might not be as how would you say, as an emergent to stop these contractions. If we're closer to 37 weeks, we might not be trying to stop anything. We just might know that we need to do specific interventions, or this child might need some antibiotics prior to, or betamethasone or something on for lung maturity, if it's something that we can't prevent. Mm-hmm. But anything up before 37 weeks of contractions that are more, that I usually will train and educate my patients, more than 6 contractions in an hour. If your water leaking, if there's leaking of fluids, if there is bleeding more than just spotting, and even after a certain amount of gestation, shouldn't be seeing too much spotting either. So if there's bleeding, if there's tightening, so that is the part, because people usually, especially if it's a first time mother, they have no idea, what do you mean? Like, what does this feel like? Mm-hmm. So I usually say, if you have tightening to your abdomen, or if you have lower back pain, or like consistent menstrual type like cramping, people can usually identify with that. I'm like, if you hydrated, you've laid down, and these don't go away within an hour, then you need some medical attention. Mm. And so usually just for them, like, hey, more than 6 times in an hour, bleeding or leaking of fluids, I need to see you. Or if we have decrease in fetal movement after 28 weeks, I need to see you. A lot of times when people come in to preterm labor, can start from other things, such as vaginal infections, or even sometimes after sex, people can start to have these contractions. But the main thing, that let's get you in, let's have some attention, so that we need to measure your cervix. Are things changing at your cervix? That's what's going to determine what we need to do next. Mm-hmm. So yeah.
Okay, awesome. Mm-hmm. I know you mentioned 37 weeks as sort of a sweet spot. So if you are currently pregnant, when is it healthy to start having contractions?
So 37 weeks.
Okay.
After 37 weeks, it's free game. Whatever these contractions want to do, this kid wants to get here, hey, fine. Yes.
Okay, awesome. So if you are currently pregnant and you're either experiencing bleeding or cramps, spotting, around when do you think that should be seen as a red flag versus not?
Okay, so your first trimester, up to 12 weeks and 6 days. Whenever I see someone newly pregnant, that's around that place in time where we start talking like spontaneous abortion, so miscarriages, right? Mm-hmm. And so even then, I'm like, hey, I'm not really looking for contractions in that trimester. It's like, if you have consistent, excruciating cramping and pain that's not going away, and if it's accompanied by bleeding, then get to an ER so we can assess how this pregnancy is going. So that would be for that trimester, right? So after that trimester, the risks usually, they go down tremendously after that first trimester period. But anything after between that and that 37-week time, you need to be seen. Like, get attention. I think when people try to take care of things on their own, most of the time I end up seeing like, patients, well, I didn't know, I was trying to wait all day, or, I tried to do this and I tried to do that. I'm like, listen, that's what we're here for. Like, that's, if you have a question, I'd rather you be here to ask here, rather than we're thinking, that it should have happened, and then now we have this adverse outcome. And so people should just be educated, like, when to come. Right. I love to say, these are your warning signs. These are the things that you need to be warned about. If you have any of this going on, especially if it's happening for an hour, I usually say, we got an hour period now. If you have immediate bleeding that's, more, that's like a period or more, then there's no need to wait for something like that. Yeah. But usually rest or hydration, people sometimes can take care of it with that. But if it's after that, or even like with Tylenol, people are having some lower back pain, because pregnancy just presents uncomfortabilities. There's some, some nuances of pregnancy, like lower back pain or round ligament pain, sometimes gets also contrasted with contractions. And so both of them can feel bad, so it's best to just, hey, let's check it out. If it's not a problem, we get to send you home, right. Or you get to go on home, and at least we know everything is okay. Mm-hmm.
Yeah. Okay. Awesome. Yeah. Thinking about later on in the trimester, what do Braxton Hicks typically look like, and what should parents do if they're experiencing Braxton Hicks? Yeah, so again, for Braxton Hicks, I would say, okay, and I also give like an analogy.
I have, like to be visual. So tell patients like this, your nose soft. That's how a normal abdomen should feel. So you have your chin. That might be, it's kind of squishy, but I can feel a little something. So that might be something that we're like paying attention to. Mm-hmm. But if we're over here in our forehead, that's really like how a contraction will feel. So I'm like, if you're going between nose, chin, and forehead, I really don't want you going past here. This should go back to here. You know what I mean? But if we're up here, I need to see you. So Braxton Hicks are contractions. They are contractions. They are a contractility of the uterus, but it's getting the body ready for that labor process. Mm-hmm. But they typically would be few and far between, here and there. So that's what I said. That's the difference. Braxton Hicks are fine, but they're here and there. They shouldn't be a rhythmic, patternized situation. If it's patternized, we might have a contraction pattern. If it's just here and there, and it's fine. You would typically not get more than 6 Braxton Hicks in an hour without we then leaning over into our warning signs area. Mm-hmm. And so people can have Braxton Hicks as early as 5-6 months. Sometimes just changing position can cause a contraction because your uterus is a muscle, or having a full bladder, your uterus is full, or different sexual intercourse. Also, when the orgasm occurs, release of oxytocin, boom, we got this contraction. And so those are fine as long as we don't keep having a pattern.
Right. Yeah. So when your abdomen gets hard, if you're pregnant, mm-hmm. then you are moving towards true labor.
Well, maybe, depending on the pattern.
Okay.
So depending on your pattern, that can be how they will feel. But believe me, a labor contraction and a Braxton Hicks feels totally different. Typically, Braxton Hicks are painless.
Okay.
But your contraction, you know what that is. It usually comes with other signs, not just a contraction. You're going to feel, it's going to be more discomfort there, more intensity, and then you're going to get your patterns, and you're going to get the duration of this contraction. So while educating the patient, you tell them the difference between like the preterm and the real labor, then they can compare and know, oh, this is different because I'm also having this too. So this and I'm in the weeks where I should be having it. So if I'm having some labor signs and I'm only 34 weeks, that shouldn't be happening.
Right. Mm-hmm. So if you are currently pregnant, then what are the telltale signs between true and false labor?
Okay. So there's always controversy, like, is there such thing as true and false labor? Mm-hmm. Well, the way that you can decipher is, okay, how are these contractions presenting themselves? Are we, if you are a first-time mother, and so you got difference between sometimes first-time and multi-gravid parents, the contraction patterns might be different that we were asking for. So I typically say, okay, first-time mother, we look for these contractions to come every 2 minutes and lasting for 1 minute and for at least an hour. Mm-hmm. And so someone else who's had 3 children who might not have that threshold, I'd say, hey, let's look 3 to 4 minutes. And then it also matters, too. I always ask about the how was your labor experience first time? Because some people deliver fast. That's just what they do. If they tell me, oh, I came in, I was 2 centimeters and I had my baby in an hour, then you don't do the 3 to 4 minutes. Okay. So it helps to know history as well. So, but typically for a mom of more than one child, I will say, hey, every 4 minutes, lasting for a minute, you get for an hour. Or if your water broke, if your water breaks, no contractions, then hey, you have time to chill, walk. Let me, do some things, walk around. You can do your ball, do some things to start your labor at home. We definitely, when I see you, I want to see you in active labor so that we can have a baby without as many less interventions as possible. So that's how you would know the difference between true and false. Are we in that time frame that I gave, or are we still skipping around? If you're having contractions every 5 minutes, they might be painful. But you're in something called latent labor, which can be very frustrating to moms because that can last for a long time. Mm-hmm. But if you are definitely educating, it's like, I know that they're comfortable with this. So I want you to, hey, I want you to get on that ball. I want you to go outside and try to walk. I want you to move around. I want you to get into the shower. Let's use some hydrotherapy, do these different things, stretching, aromatherapy. Do all those things that you can do at home if you're delivering in a hospital setting. Now, that's, again, if you're delivering in a birth center setting or a home setting, then they're doing this at home already anyway, just preparing and waiting for that labor to come. Yeah.
Okay, cool. Mm-hmm. Yeah, so I think what you mentioned was the 411 rule. So what a lot of questions that I get on my TikTok, for instance, is when should I go to the hospital if I'm anticipating giving birth? Like, what are the telltale signs? So typically when I've chatted with midwives, they mention the 411 rule as a time when you should go to the hospital. So what is the 411 rule, and do you think parents should abide by that?
Okay. I typically don't use the 411. I usually use like a 2-3.
Okay.
I would use like a 211 rule.
That's good.
Although I want people to be active,
Yes.
so I don't have to do, especially if this is a patient who desires a natural physiologic birth, like, hey, let's get in here already rocking and rolling, then I'm going to work with you when I see you.
Right.
So 411, 4 minutes apart, to me, it still can be in that latent phase. Let's move it a little closer. Like if we can get to 2 to 3 minutes apart, then yeah, come on in. Now it also depends on how the mom is tolerating things. I've seen people who having contractions every 6 minutes, but every 6 minutes is excruciating. And I don't believe in trauma in labor. If that's how the person is experiencing it, I don't believe in that, because that's what they remember. And we want the experience to be, it shouldn't be a traumatic one. We should, it should be something that you don't have to look back and be like, oh my God, I would, that's where you get that. They feel like death is upon them. And no, we don't want that. So it depends on, who you're talking to. I typically like to go closer, like 2 to 3, 1-1. I believe the 1-1 is consistent. Parents can abide by them, and depending on, like I said, how's the toleration of these contractions, how far they are away from the hospital. That's another thing. If someone has been having these contractions and I have patients that live quite a ways from the hospital because we're just the nearest to them. I don't give them the 2-1. I'm like, listen, I know you're coming from here, so go ahead. You start coming towards me if you get like every 3 to 4 minutes, lasting for 1 minute and for 1 hour.
Okay, cool. A lot of questions that I get on my TikTok as well is like, what if I live really far away from the hospital? So when thinking about preparing for birth, do you recommend that parents move, for instance, or get an Airbnb closer to a hospital? And when should they plan to go?
Okay, good question. I would always tell patients, try to identify if you have a family member close to the hospital, amazing, right? If you don't, let's try to locate some room, a hotel, Airbnb, where you and your family can go. And typically you can have your normalcy of life there, but that you can labor there, because there's times that moms may feel like they're ready to go to the hospital and they get sent back home. You don't want to drive all the way back home.
Right.
To get them all the way back. So if you can find something closer. Now, when would you start to prepare that? I would say, when things start to get kind of regular, and labor is so unpredictable. I think that's why I just love it. Labor is so unpredictable because you could be doing one thing 1 minute and next thing you know, everything is shifting. But there are some precursors, like some people they lose their mucus plug. Now, mucus plug can come out 2 weeks before things even happen. But people just usually feel crampy, and they just, they usually have some bloody show going on. If they've seen their provider maybe days before and they had the membrane stripped, things like that. These are things that they can kind of, okay, let me put a compass out as to where I should, be getting this Airbnb set up. But if they can move closer to the hospital, that's amazing, rather than having that panic of driving and things of that. Now, another thing, when patients do live a ways away, I think it's also important that they should know, if your baby is not moving, if your contractions are going way different than you thought, things are moving faster, don't try to come here. I say, listen, don't try to come here. If there is, I know you may not want to be at that particular hospital, but if they have a labor and delivery unit and you can get there faster, we want you to be safe above anything. So if it's just, it doesn't happen, because sometimes these babies, they do how they want, and the body is just dynamic and it does what it wants. And if it's going a lot faster than what we anticipated, go to a near place.
Right. Okay, awesome. Yeah, it's interesting that you mentioned mucus plugs, because one of my most viewed TikToks in the pregnancy space is about mucus plugs.
Yes.
I think a lot of pregnant parents are surprised at what even a mucus plug is until maybe they see their own. So what is a mucus plug, and what does it mean when it falls out?
So you have between the cervix and you have your uterus, and you have your amniotic sac that's in there. But when you enter into the cervix, like when we're doing manual exams, there's layers of just mucus that protects that cervix and just kind of keeps things out from, outside from coming in. And so once all of that kind of sheds out, it's not a beautiful sight. I think that's the first thing that they that they recognize. Is like, what is this? That's what they didn't expect it to look that way. So I get pictures sometimes like, hey, this is what I got. I'm like, okay. That's usually, that is your mucus plug. It's not beautiful, but yeah. So, but that can happen weeks before. And so then people are thinking, oh my God, my mucus plug is out. Like something's wrong. Like I'm going to have complications. I'm like, no, that just means that we're moving forward to where we need to be.
Right.
But I try to tell my patients, like, don't put so much weight on that though, because it doesn't have to mean a whole lot. Mm-hmm. Although it can. So once that has happened, we know we're progressing.
Right.
But look for it to progress. But the main attraction is the contraction.
Yeah.
Yeah. So that's kind of what I kind of teach. Yeah.
Okay. Awesome. So I know earlier you mentioned your abdomen getting hard and like this. So what does it mean if you're currently pregnant and your belly gets hard? And should it be as hard as your nose until birth starts to get closer? Then it should be as hard as your forehead?
Well, good contractions, like nice, intense contractions, feel like this.
Okay.
They feel like that's like the closest thing that you can kind of give someone on their own body to compare it to.
Yeah.
Yeah. Nice, intense, beautiful contractions that are going to get the cervix nice and dilated and, and effaced is going to be like that.
And then it goes back to your nose.
It will go, and after that's over, it goes back nice and soft where you're able to, palpate it and feel it. And it's nice. But then you might have ones that are not so intense. They feel like this. Or sometimes I'll use my chin, but it depends on how cheeky you are. I'll just go with these three. But, it'll be midway intensity might be here, so they might experience all of these different kinds. But your indicator is the how are we progressing? How's the cervix, the cervical progression?
Right.
So are these working for us? Mm-hmm.
Okay, cool. So one other indicator that I feel like a lot of folks use as they're getting closer to birth is kit counting. So in your opinion, when it comes to birth and pregnancy, what is the importance of kit counting and how do you suggest parents kit count?
Oh, yeah. Kit counting is everything. That is to me, in the third trimester is one of the most important things you can teach. Kit counts. Kit counts are there so that we understand and we are able to monitor and assess how the baby's well-being is inside, because you can't see anything. You can just, be able to feel. And that is the indicator of how the kid is doing. So teaching kid, I usually start kind of mentioning it around 25, 26 weeks, but on 28 weeks is when we start the kit counting. I'm telling them you're doing this every single day until you get this baby in your arms. Big time. I've had, you see patients who say, yeah, my baby wasn't moving for 2 days. Mm-hmm. And I cringe every time. There's how many times have it been that to where you go put a monitor on and you get nothing. That's what we are trying to avoid. We don't want that. And sometimes moms are super busy. They have other children. They just don't have time to sit down themselves to kind of see what's going on. Or if they have a baby that moves all the time, they just think in their mind like, this is the norm. But you have to do it every single day. So every single day, sitting down in the quiet to where if you're a working mom, that you can be in a space where you're able to check things out, where you can feel these counts, and then you have a baby who has, they change their patterns, just like they're growing, they change their patterns. Sometimes they might want to be moving for a couple of weeks or about 2 months in the morning time. Then they switch. Okay. Now I'm a nocturnal kid. So now I'm up at 4:00 in the morning. So it can be tough, but, usually after eating or drinking and things of that, you get this baby who will respond. And so sitting down, you give your moms, I tell them you got 2 hours. You're giving this kiddo 2 hours to give us 10 kicks or movements.
Okay.
If that did not happen, usually I say, hey, especially if there's complications involved, if we have a gestational diabetic mom or, we're dealing with some gestational hypertension or anything that could compromise the cardiovascular of this placenta.
Right.
So after an hour, if we're not halfway through, at least 5-6 counts, I need you, let's sit down, drink some cold water, and lay on left side, and let's make sure we get the next 5 within the next hour.
Okay.
And then you get some moms, they sit down 15 minutes, they got the counts. So fine, you got the counts, you can stop. But if we are past, I don't care if it's 2 hours and 1 minute, I need you on your way so we can do an evaluation. Mm-hmm. And sometimes it depends on where the placenta is implanted.
Because posterior, anterior.
Yes, because if you have that anterior placenta, it's like a cushion. So this kiddo's in there just like punching a pillow. And so moms can't typically feel the kicks and movements as much. Mm-hmm. So when someone like that, hey, I don't care. I'm like, listen, if I need to see you, if we need to put you on a monitor or see, however, or evaluate this baby as many times as you don't understand that you felt it, I'd rather.
Okay.
Okay,
mm-hmm. So it's pretty much in any given 2 hours of the day, or it's right after you eat or drink and you're pregnant, then you should set aside 2 hours to count kicks.
It's really any given 2 hours because, like I said, everybody's so different, but just a 2 hour period of time.
Okay,
for sure.
Awesome.
Mm-hmm.
Whenever I've talked about kick counting on social media, I get some comments that are along the lines of, like, kick counting gives me anxiety. I already have so many things to worry about. How can you stress me out by asking me to do more things in the day? What do you say to parents that feel like they're already having too much anxiety when it comes to kick counting?
Yeah. So in that situation, that's already telling me I have to approach that sensitively because it sounds like there's some other psychiatric or psychological things going on.
Okay.
So that's when I want to go there first. Like, let's deal with the anxiety first. Like, where is that coming from? Is that because this person has had a bad outcome, or they know people who's had bad outcomes?
Right.
The internet is so amazing, but it can be so destructive at the same time because people read things that are terrible and then their anxiety levels are on 10 all the time throughout their whole entire pregnancy. So that's when it comes in. Providers, we don't just take care of these other things, but you have to sometimes you have to be a therapist. Let's deal with the anxiety of this, like what's going on, so we can try to see how can we hone in on that so that I can help to lower that with you, or let's cope through those so we can do those, because we have to do those kick counts,
Right.
Just explanation of how important, what's the reason why we're saying this. And with someone like that, you don't want to give them, well, hey, I've seen many outcomes where a mom, was not having her baby move, and then she went to bed, and in the morning time we didn't have a heartbeat. That would just take that particular person through the roof.
Right.
So you don't want to do that. You just want to give them the reason why. Also, too, another important thing is never go to sleep without completing your kick counts. That's the worst, because when you're sleeping, you're not feeling things and you're not paying attention. And so that's, to me, I always say, don't ever go to sleep. Don't ever not complete it. And so that we wake up in the morning and not know that we completed or not. So with that, we have to take responsibility there. That's a big thing. Because a lot of times patients or clients or parents, they want to put everything on the provider to make it happen for them. But we all have to be responsible for the outcome that we want, which is a safe pregnancy, safe delivery, mom and baby safe and going home. Mm-hmm. But everybody has a role. So even as a patient, you're carrying your mom, you have a role, and it doesn't stop. It's not going to stop here. After this baby's delivered, you're going to have so many other things that's going to come up that you're going to have to do. So let's start getting used to what we need to do right now. Mm-hmm. And so that being one, people do that a lot of times when there's certain testings that we need done, and they feel like, why are you asking me to do extra? Well, we need to find out. We need to know these things in order so that we have a safe mom and baby.
Right.
Yeah.
Okay, cool. Thinking about preparing for a safe birth, what are your thoughts on a home versus hospital birth and just general safety measures with both types of births, or birth center as well?
So birth center and home births, I think, are amazing. And as you sit down with the midwife during the intake of a home birth or a birth center facility, there's going to be criteria. Every mom does not qualify for a home birth. And that's what I try to talk to patients about, that I'm, that are not my in-hospital moms, but just if I'm definitely, like with my lettuce birth practice, if a person is trying to figure out where they should deliver or where they would like to, are you going to qualify? So you do have to go, and it's almost like this provider who's receiving you into their home birth practice or their birth center, they're also want to find out, are you a good fit for being here? Because the responsibility of that provider is to say, you're diabetic patient outside of pregnancy, So now your insulin dependent mother, you might not fit into
home birth.
Yeah, into a home birth or birth center situation. But what I would like to see is that people can also point those particular patients over to a hospital where they can still have an amazing birth. You can still have an amazing provider. But you got to look for that. You seek it out. And I think even with birth centers, even hospital birth center and home, you need to vet out your provider. Vet the provider out, vet the facility out. Is that going to be, because even if you have complications, it still should be somewhere that still matches with your philosophies, can also give you some of your birth planning, maybe not everything. You might not have been able to stay at the home, but we can still give you a safe, amazing birth at a hospital. So vetting out home, birth, hospital, and birth center, you need to vet the provider, vet the facility, to make sure that every one of those is a safe place to be, and there's someone or a facility that matches with your, with your expectations and what you like.
Yeah, that's awesome advice. Yeah. When it comes to the cost of birth, have you seen differing costs in home versus hospital versus birth center birth?
Absolutely. And that's another thing that people don't take into consideration. And, home birth midwives, amazing. These are amazing providers because a lot of them, it is cash, it is cash pay. And so, although you want to be able to give moms this experience of no interventions at all, and give them this opportunity to have the birth that they visualize and they want. But if it's cash pay, then if that can't happen, these women or men can't operate on just our hopes and wishes, so they work as well, and they work very hard. So it's cash pay. Some midwives in home birth settings and birth centers do accept some level of insurance as well. And so some people, it just depends again on your qualifications of, can you pay, can you also do this? So in the hospital, depending on whatever insurance coverage they have, or Medi-Cal as well, those types of things are also accepted in the hospital. And that is the thing too. I'm glad you bring that up, that people think just because they have Medi-Cal that they don't have a right to also vet out the facility that they're going to. That's not true. Just because you have Medi-Cal, that doesn't mean that you should just take whatever that's handed to you. No, please. And that's what I advocate for patients. You don't have to stop there. Go find out who accepts your insurance. Does this facility still line up with what you expect and want? So, yeah.
Okay, yes. Cool. Do you find that a home, hospital, or birth center birth, one of them is cheaper than the other?
Well, absolutely. I mean, for the fact that in a hospital they might offer more for insurance, you know what I'm saying, or it might be in that Medi-Cal facility you don't have to pay anything. You know that you can have your birth, here at no cost or less cost. So probably I would say that the hospital would be the cheaper of them. But in that, you still should expect dynamic care,
right?
No matter what,
Right. Okay. Awesome. Cool. So I'd love to chat about midwifery as well, especially because you're a midwife and really passionate about it, which I love.
Right.
So in your opinion, what is the importance of midwifery? And also, if you don't mind, even defining what a midwife is. Like, even I was mentioning to my roommate earlier, he's a 25-year-old man. And he's also gay, so he just knows very little about birth. He didn't even know what a midwife was.
Okay.
So I was explaining it to him. So yeah, I feel like there's just still so much ignorance around midwifery. Right. So I'd love to get your thoughts on why midwifery is important to consider if you're pregnant, and also what a midwife is.
Yeah. Okay. Well, please, I want you to tell your friend that there are male midwives too. So if he just, happens to get inspired, right? Okay. But midwifery is a long, a legacy, if I would say, a historical craft of birth.
Right.
Okay. And I myself came from a legacy of midwives. I did not know that until actually I'm sitting here talking to my grandmother, and and I'm like, what? So it makes me wonder, like, hey, was this already in me from before I even knew it myself? I believe that midwifery is a call. I do not look at it as a profession. I do not look at it as a job, because you have to, I think about birth when I'm not even working. I'm studying, I'm trying my best to figure out what then next that I could do when it has nothing to do with the time clock or the money. It is a call on my life, and I think that's why I'm here. But it's a long standing. There's traditions of midwives in the I would say in the parishes of the South, where Black midwives, that people call them as granny midwives, were performing births and teaching the younger how to do this. And so there it would go down and through the legacy of this particular family, or in these in these circles and communities, young girls who wanted to learn, and they learned through the apprenticeship of this woman who was like the healer of the community and doing births all over the community, not just for black families, but also in white families as well. They would have them to come, sometimes accompanied with the doctor to do this. So, man, that's a whole, it's a long thing how that was, and also not just in Black communities, but also in the places of Mexico, way, in those areas and where we're not established like we see them now. Birth has been there. Women have been doing midwifery. Midwife means with woman. That is the word. Midwife means that you are with that woman. And so they were there, not just, but feeding them, making clothes for them, babysitting their other children, at the same time taking care of their pregnancy, and then helping them with their births, and then afterwards too as well, into postpartum. So midwifery has a long history. You can probably trace it back to every culture. You're going to find where some woman was helping them, and it wasn't doctors. Right. There were no physicians. There were no medicine. There was not medicine like that. And so in the African American culture, it came to where, now the physicians want to like eradicate the traditional ways of midwifery, and now we're requiring that education was a part of it. Okay, so here are these women who may have not been so skilled in reading, skilled in writing, for they didn't have the money to do these types of things, didn't have the resources. And so some of them did though, but just maybe money might have been the resource. So if you're gonna red tape me now I can't perform and do for this community which I had been doing. So then their hands were tied. Right. Now, some of the women did go forth to receive this education, and they became those nurse midwives, but of course, the racism that was abroad at that time, it still is now, but very much more prevalent then and that timing. And then now these women have come out of the homes. Now you want me to go into this hospital and now do what you're telling me to do, that you're not going to allow me to do it the way I was doing it in homes where it was safe for the moms, and so on and so forth. So it's a long history. Midwifery is important even today. And there's such a shortage of midwives. We see, the new age medicine, and people, a lot of times when they want to deliver a baby, they want to be an OBGYN doctor. And so I already had a long history of labor and delivery experience. I was already with women. And when I was introduced to midwives, it's funny because it wasn't Black midwives that I got a chance to see midwifery practice with. And then I began to learn of the tradition. And then, like I said, end up finding out that I do have legacy in my own family from midwifery. But midwives are I believe it with my whole heart, that the midwives are the answer to our crisis that we are experiencing right now. Why? Because it has been proven that midwives are going to the midwifery model that we learn and that we practice in, it will lessen the occurrence of C-sections. It will lessen the occurrence of vacuums and any kind of instrumental births that could potentially cause more harm and problems. It also, being with the midwife, has shown that preterm labor was lessened in those particular patients that were cared for by midwives. And I think it has to do with a lot of compassion that we use and also in our practice, not so only just the hands-on, but the listening, the jumping into the situation with the mother to really hands-on deal with them. And sometimes when you put your hands on something, you can feel something that you can't diagnose right off just from tests and whatnot. So many times I will do something because my inner says, no, check her one more time, or check her fluid, or I listen to myself all the time. Every time that's why you can't be distracted. I had a patient, and she was just measuring. Really, that's why midwives are needed everywhere. They're needed at home, they're needed at birth centers, and they are needed in the hospital. You have women who need us, and I am a hospital birth practicing midwife. I could practice wherever, but this is just where my heart is at the moment, because there are women who don't qualify for those other spaces, but they're going to see me.
Right.
And so midwives need to be at every stop because of what we're talking about right now. But I had a mom who her fundal height was just measuring way, way beyond the weeks. And I'm like, this is weird. Like, she hasn't gained this much weight. Like, something's going on. We're not diabetic. Like, let me send her off. I need to send this one lady now. I felt like I got to send her now to ultrasound, which I did. Come to find out that right away, she was, her care was transferred to a higher level of care. Her baby had a large mass they could see that was connected to or near the baby. And immediately she was booked for surgery. Like, the next day, everything got moving so fast. Now, had I just not like, kind of like trusted, I knew something. I could have said, well, right, I'll do this ultrasound next week. Let me check her the next time. Something said now. And so I didn't know what happened afterwards, because it was definitely transferred out of my hands to something higher level. Well, I saw this mom again. She came back to me 2 years later. She's pregnant again. So we're talking, and I didn't remember. I remember the case, but I didn't remember this particular mother's face. She stood up and she said, I just want to tell you thank you. And I'm looking like, okay, like, okay, yeah, okay. And so she began to go over the situation. I was like, yeah, I remember that. She said the baby had a mass that was so large connected to and that was growing under the neck of the child that they had to do an emergency C-section to deliver this baby, then emergency surgery on this child. She said, do you know that I didn't tell anybody, but I was getting my prenatal care here, but I was going to deliver my baby at home. She already had it set up.
Oh, wow.
She already had it together. So nobody was looking for these ultrasounds because everything had been fine. She said, I already had it set up. She said, had you not did what you did that day, she said, I would have went forth with my plan. And I or this child, we both would have probably not made it. So she hugged me. Oh my God. So we're standing there just crying. And that's the importance of why. So midwives are here for so many different reasons, and you might get some complications. It might not be just this normal pregnancy, but that's why we're here. So I'm not here to perform medicine, but I'm here to use my discernment that I believe that I am equipped with as a midwife.
Right.
And so, yeah, midwives are here. I believe we are the answer for what we got going on. We need more. In the state of California, we only have 2 midwifery schools. But there's many routes that midwives can go. You don't have to be an RN. You don't have to be an RN first. You can go another route where you're entry level midwives. We just need more because the population is growing. People are more abreast that the midwives have we have these qualities, and we do have these statistics that is shown that we are definitely lowering C-sections and and things like that, and we do provide for low intervention or no intervention births to women that's what they desire. So yeah, we're the answer.
Yeah, I know. That's a great answer. Yeah, it's interesting because I think in the United States, since midwifery is so, it's so much more uncommon when compared to especially the UK or Europe or anything like that. When kids are young and they are interested in birth and helping women's health, I feel like the automatic answer in the United States is to, become an OBGYN or even potentially an LND nurse, but people never think midwife.
Right.
So what would you say to folks who are curious about finding educational resources related to midwifery and how would you want them to think about midwifery as a potential occupation?
Sure. And like what you said, it is such a misnomer. I have so many people that sit with me. They're booked with me. We're there together and they're like, what is a midwife?
Yeah.
I'm like, wow, but that's so not how you want to do this. You need to know who your provider is and what they do. And so you're absolutely right. The resources, I think people just don't know where to go. Like, how do I start? What do I now? So and even as an RN, I had no idea for years because for years where I was at L&D nurse, there were no midwives. So I didn't know what they did. I didn't know what so when I finally got exposed, so exposure is a big thing. So now then I feel like it goes back on the midwifery profession. Right now I do take big part in the California Nurse Midwives Association, and in part with the reproductive justice, anti-racism committees, and like health policy and things of that. It's our job. We want to get the word out. We have to tell the community that we're here. Like, do you know what a midwife is? Let me tell you what we do. Let me show you how you can get that education. So resources, I mean, if people are even California or not, I had to go outside of California to obtain my midwifery education, but it's there. There's online pathways. There's, like I said before, entry level pathways, but you can start off. I mean, I think I might have started off with just Google. Like I put in, once I knew that that's something that I wanted, I put in midwife, it's nurse midwife. And because at the time I was an RN, and so I knew I could take that pathway. And then, several things come up. You can also visit the ACNM website. There's many resources there as well. And then if in California, the CNMA website as well, many things there to let women know how they can get their hands in there. Like you said, how would they even know that they would want that? Well, you definitely need to have a passion for something like this, because it's a tiring job. It can be very physically overwhelming sometimes, but when you have passion behind what you do, for some reason you're energized. For some reason, every time I get ready to go and do it again, I get the same passion fuels me. So people have to be very much interested. It is not, people might say, oh, well, midwives, they make this amount of money. People want to make it about the money, but that's not what's going to push you for years in to come. That's not going to give you longevity, because that never makes people happy. Money never makes people happy. You have to want to see the women better. You have to want to see babies, this, and especially here in the United States, like you brought up the UK, there's midwives all over the place. So, but as you see, they don't have the statistics that we have here in the United States.
Right.
So that's why I said we're the answer. I believe that collaboration is key. We have to collaborate with the doctors. Let's develop teams that understand that, hey, I know what we're trying to get to, and we want to eradicate these numbers. So midwives have to be respected as what they do.
Right.
The doctors that I work with, they give us the respect that we need to be able to practice.
Right.
The autonomy that we need to be able to practice. It's not like, hey, you got my hands cuffed and I do what you say. Well, I know how to practice in this craft. I know how to practice here. This is what I'm expert in. And you have to trust me.
Right.
And so if I need you, please trust me that I'm coming to get you, because I need you to collaborate with me on this, because we need to see this result, or I'm having a problem. So, it's just a lot to it. But as far as resources, and people can always reach out to me as well. This is something that I also do in my Let Us Birth practice, is also to mentor those who are looking for which pathway they should go. A lot of people always ask me, hey, this is where I'm at. I already have a master's in this. What can I do, to obtain their midwifery? So, yeah.
Right. Okay. Awesome. Why does midwifery generally come with less complications for birth?
I believe because we're not intervention led.
Right.
If we don't have to use interventions, there's no need. Like sometimes I work with nurses and they're like, hey, my patient's over, she's 9 centimeters and, she needs her water broken. No, she doesn't.
Yeah.
She doesn't. Her labor is still moving.
Yeah.
Now if there's a time that I need to assess that fluid and I need to break her water for whatever else might be going on, then fine. But it's not necessarily have to be an intervention for delivery. You know what I mean? And so I think the model that we go with, less interventions, most natural physiologic birth, is what we want. Then that's what our goals are. Of course, now those midwives who work in the hospital, sometimes there's policies that are in place that like your home birth midwives would not be cool with that. Like, hey, listen, this birth it's natural, it's gonna happen on its own. So when you're in the hospital, then you have other things such as inductions that are involved. But I understand both. I understand induction, right. I understand augmentation, and I understand natural. I can do them all. So if I see a mom who doesn't need these interventions, we're not getting them. Okay. If there's no need for it, then I'm not gonna even with nothing to do, you know.
Right.
So that's my main goal. But you know, there's different things that come in for different reasons. If somebody might have certain complications that we have to use these other interventions because of that induction or whatnot, and so that's, you know, those are different subjects for different times. But yeah, I think that's why people want them more. So,
what is considered the most common complication for birth?
Ooh, there's so many. There's so many.
Maybe top 3 to look out for.
In birth or pregnancy?
Let's do both.
Okay, so let's say in pregnancy, I would say the most thing that you see would be like your gestational diabetes. Either most you see gestational hypertension more so than chronic hypertension. Chronic shows up before 20 weeks. Gestational hypertension shows up after 20 weeks. You most of the time see that. And I'm going to use this complication because people don't want to make this a complication, but it is a complication. But obesity. Obesity is a complication because that leads to other problems. And that's one that people try to, you know, and patients don't want you to touch it. Oh my gosh. They don't want you to touch how much weight they're actually gaining in pregnancy, but that can cause a lot of other problems.
Yeah.
So I'm going to put that as one of the top 3.
Okay. What about in birth? What are the top 3 complications in birth?
So in birth, I would say hemorrhage. Hemorrhage is one that's it can be prevalent. Shoulder dystocia is another one. And possibly maybe like a failure to progress. What might be like another one that you see a whole lot, which then, you know, is a bummer because that sometimes can lead to cesarean, whatever, you know, leads to cesarean section. But even with patients who come in for inductions, like even when a midwife puts their hand on an induction more so than others, we typically see more success because we'll go for other modalities like a Foley balloon rather than just jumping to. I've seen patients come in like this is a first time mother, her cervix is not favorable, and you're going to start Pitocin. Well, we're going to go back for a C-section because it's going to fail. We need to prime this cervix, get it nice and ready for whatever we're trying to do. So that's another way. If you give that to a midwife, we're going to do it differently.
Okay.
We're going to do it differently. We're going to make sure that this mom has a chance, not so that we end up in the OR. So that's what we're trying not to go back there, you know, for go there for any reason or have any kind of complications. So.
Okay. What would you say would be your top 3 tips for someone if they're currently pregnant? And these would be tips specifically geared towards avoiding complications.
Okay. So avoiding complications, education.
With a midwife.
With the midwife, right. If you know what you're looking for, if you know what are your abnormals and what your normals are, that right there will hands down be a lot of the battle won. Because if they know when to come when that preterm labor, if you know what that's supposed to look like, if you know this baby is not moving appropriately, if you know these things, knowledge is so much power, then you can go get attention. That's, to me, that's a big one. And then prevention, like with the obesity, let's adhere to where we should be. So if you're supposed to gain 25 pounds, if you gain, and I've seen it, 90 pounds in a pregnancy, I've seen 70, 60 pounds. We are setting ourselves up for risk.
Yeah, and that's largely due to overeating.
Yes, or just eating, you know, with no concern, like fast food and processed foods and, you know, just overeating and just indulging. People really believe the lie that you're eating for 2 people.
Right.
And I tell patients, no, a baby never tasted your fries. And I've never met one baby that I birthed or helped to birth that had a French fry or some chili cheese fries. Never. I said they don't eat like that. So don't tell me that your baby's craving a banana split. It doesn't work like that. So, you know, I think that's just adherence to, if we see risk coming up or we see something that's potential complications, if your provider's saying, hey, let's stay in these parameters like this, and it's not for malice or it's not because we just don't want you to enjoy yourself, but because we see something down the line that could potentially be a problem.
Right.
And then let's see another prevention. Those 2 are good ones. Another prevention would be, I would say, being able to advocate for self if you know something's wrong and you might not have got the answer that you needed or the answer that you know, or someone who listened well enough to give you the attention that you were supposed to have. Don't stop. That's a big one. Just because one person say, oh, no, there's nothing wrong with that. That's how, that goes. If you know in your heart of hearts, which again falls back to your education, right? If you know in your heart and hearts that that's not true, or no, this is not right, then you just, even if you don't, you need to stop with that person and go to the next. Don't ever stop when you know something is not right.
Right. Okay. Those are great tips.
Yeah.
Cool. Well, my last question for today is, how would you define a positive birth experience?
A positive birth experience is one that was planned out, that a mother, or, and I would even say, and I would even lead to say a birthing person, planned that birth out, and they were able to say, hey, I want this. I want this and I don't want that. I would like this and I don't want that. I believe that I like to see people, let's do a plan A and a plan B, just in case if our plan A doesn't go as planned, or there's some turns along the way that may have scratched off something on your number 3. But how can we still how can we still be satisfied at the end? We might need a plan B, and that's okay. If things might change, and it also prepares mothers to not feel like failure, to understand that the birth is something that always, you can't predict everything. You might put something on your list that might not happen, or it changed up. So being able to plan, being able to get as many things on that plan list accomplished, and at the end of that, end of the road, that we have a healthy, safety, that we have a safe, healthy mother and a healthy baby. So that's what I think is a beautiful birth experience, that when you close your eyes and thought about it 2 weeks later, 1 year later, that you could say, man, that person really cared about me, cared about what I thought, cared about what I felt, and they helped me get to what I wanted safe.
Right. Okay, that's awesome. Well, if folks are looking for a positive birth experience in LA with you, how can they best find you? And how would you suggest, thinking about midwifery or anything like that?
Sure. So I have, at this moment, I am currently a full practice midwife in the Inland Empire, where with Kaiser Permanente, where if people did not know, then almost every Kaiser has midwives. And so I don't know that people know that. Sometimes people are like, oh my God, I didn't know that.
Yeah, that's good to know.
But every Kaiser has midwives. So you can go and find people who function and who operate with the midwifery model, and should, in most Kaisers. But that's where I'm at. So I'm there. Also, I have also since now been in midwifery for almost 7 years now. And then, like I said, having 15, 16, 17 years of L&D experience with women and women's health, have began a midwifery telehealth practice. So I don't actually see hands-on patients, but the education is a big thing to me, no matter who you're seeing. But if it's something that you don't understand that's going on in your birth or in your pregnancy or preconception or postpartum, I'm here because telehealth is slotted, and especially in the state of California, as even education. Because if I can empower you to be confident enough to ask questions to your provider, enough to advocate for yourself in birth, with the knowledge of why, not with the intention of causing a environment of contention, but how to advocate for yourself with the proper words to say, and things that you can convey with people understanding what you're saying, and it doesn't look like you're trying to be, aggressive.
Right.
And the things that you need to know, and you be able to be confident with it. That's what Let Us Birth is. And also coaching other midwives who are even in practice, who are burnt out, who just kind of like need that refreshing, or those who are looking for entering into the practice and just need help with guidance on how to get there. I'm also there to mentor as well. So that's what Let Us Birth is. I believe that, like I said, never ever in my life have I seen education. I think that that's also going to be so many complications that people that lead to these horrible maternal mortality rates. A lot of them had to do with moms not understanding what's going on with their bodies. Mm-hmm. When should they say this? And if they didn't get the answer that they needed because they knew that what was going on was abnormal, then they need to go seek other help. It had to do with just not understanding, not knowing that there was a problem going on.
Right.
And when to say something, like, you know. And so because I know there's so many patients, providers sometimes don't spend the time that they need to educate. It's quick. It's so many people to try to service, and it becomes like an assembly line, and we can't let that happen. So that's what Let Us Birth is here for. So yeah, find a midwife somewhere. But everything still, vet out every facility, vet out every provider. It is your right to have someone who cares about you, who's going to give you safe care, who's going to give you amazing knowledge base, who's going to be open to the evaluation of, like you said about birth centers, open to the evaluation of accreditation facilities to come in, or the bureaus that are in place for that accreditation, those boards. They should be able to open up. That's their seal of excellence. Mm-hmm. So make sure these things are in place. Don't just jump in just because Instagram is showing you now that women are having babies in pools or things like that. People get really visually thrown off.
Yeah.
You still need to vet them. I don't care if you want to have a water birth, you want to have a hospital birth, you want to have a home birth, whatever it is. Vet your facility, vet your provider.
Okay. Yeah, that's great advice.
Yeah.
Awesome. Well, I really appreciate you being here today.
You.
It was an amazing conversation.
Thank you. I appreciate you guys.
And yeah, I really love all the work that you do.
Thank you. Thank you. I appreciate it. I appreciate you guys for highlighting midwifery. Because I think for so long it's gone unspoken.
Yeah, and it's so much safer. I think that's what's crazy is nobody talks about it, and there's way less interventions.
Yeah. Yes. So
yeah,
thank
awesome.
you. Thank you.
Cool.
Thank you.
Cool. Are we good?